Thank you very much, and welcome everybody. Our topic is principles and general approaches to managing co-occurring substance use disorders. After this presentation, learners can expect to be able to describe the risks associated with co-occurring substance use, describe the tools that can be used to screen for co-occurring substance use, and outline key principles and treatment approaches for co-occurring substance use disorders. Co-occurring substance use is when two or more substances are used at the same time or close in time. This includes various combinations of prescription drugs, including benzodiazepines and opioids, over-the-counter medications, unregulated drugs, and regulated substances like tobacco and alcohol. Co-occurring substance use is also increasingly occurring unknowingly, related to changes in the unregulated drug supply. For example, with the addition of novel contaminants to the unregulated opioid supply. Co-occurring substance use may also occur knowingly in an effort to achieve a certain effect or outcome. For example, to enhance, balance, or counter the effects of one substance with another, to create an effect similar to an unavailable substance, or to increase or prolong pleasure, or in an effort to minimize harm. A 2022 report from the Canadian Centre on Substance Use and Addictions suggests that on average, people accessing harm reduction services reported using between 2.6 to 4 different substances in the previous 3 days, with more than half of survey respondents identifying opioid and stimulant use. National research surveying people who accessed community-based substance use treatment services found that the majority, or 55% of surveyed individuals who used drugs reported using more than one substance at a time. 57% of all drug poisoning deaths involved more than one substance, which is an increase from 39% in 2014. And of all opioid-related deaths in 2017, around 2/3 involved at least one other substance. The most common substances involved in co-occurring drug poisoning deaths between 2014 and 2017 were opioids, cocaine, and methamphetamine. Next slide. While there are many combinations of multiple substance use, common combinations include alcohol and commercial tobacco. Alcohol use disorder and tobacco use disorder are the most commonly diagnosed co-occurring substance use disorders. Benzodiazepines and opioids, cocaine and alcohol, opioids and alcohol, opioids and methamphetamine, and commercial tobacco and other substances. Slide. Individuals with co-occurring substance use disorders are more likely to have comorbid physical and mental health challenges, such as increased rates of liver disease and HIV, and higher prevalence of personality and mood disorders. They also tend to experience greater severity of alcohol or tobacco use disorders. Mixing stimulants, for example, cocaine and methamphetamine, can increase the risk of brain injury, heart attack, and stroke due to increased heart rate and blood pressure, and increase the risk of seizure. Using depressants together, for example, opioids and benzodiazepines, or opioids and alcohol, is associated with an increased risk of respiratory depression, drug poisoning, and death. Combining stimulants and depressants can cause severe stress to body systems as they receive mixed signals, both increasing and decreasing central nervous system effects, masking some effects, while adding euphoric effects, leading to additional substance use and subsequent drug poisoning death. People who drink heavily and who also smoke experience more negative consequences. including cognitive impairment and increased risk of cardiovascular disease and some cancers. And among individuals who use stimulants and opioids concurrently, which is particularly prevalent among people who use unregulated drugs in BC, the likelihood of experiencing a drug poison is notably higher than for people who use opioids alone. Routine screening for substance use is recommended. Clinicians may use screening tools that assist for multiple substances, or they may use substance-specific screening tools. The ASSIST, TAPS, and DAST tools screen for multiple substances. In 1997, the WHO sponsored the development of interviewer-administered alcohol, smoking, and substance involvement screening test, or the ASSIST, which is a provider-performed screening tool for use in general medical settings that has been validated for identification of adults at high risk for substance use-related harms. The Tobacco, Alcohol, Prescription, Medication, and Other Substance Use Tool, or the TAPS, was developed in 2016 from a multi-site study within the US National Drug Abuse Treatment Clinical Trials Network. It has two components which combine a screening component, or TAPS 1, with a brief substance-specific assessment component, or TAPS 2, for those with a positive screen. TAPS 2 identifies specific substances and risk level ranging from problem use through to substance use disorder. The TAPS can be administered by the provider or self-administered by the person receiving care. The drug abuse screening tool was developed and validated by Harvey Skinner at the Addiction Research Foundation in Toronto in 1982, which is now the Center for Addiction and Mental Health. It assesses harms related to substance use, excluding tobacco and alcohol. It can be clinician or self-administered. Next slide. Okay, thanks. Where possible, treat co-occurring substance use disorders concurrently. There may be benefits if side effects are offset in the treatment phase, as well as psychological benefits for the patient who wants abstinence from all substances. It can be done safely, and sometimes it's the safest and most efficient pathway. That being said, understand a person's reasons for using multiple substances and align treatment plan with their goals as much as possible. If needed, triage according to which substance use disorder has the highest and most immediate risk of mortality or other harms. Provide trauma and violence-informed, culturally safe, and person-centered care. Safety should be prioritized. Pharmacotherapy should be selected with consideration of possible drug-drug interactions and other safety concerns. Withdrawal management for co-occurring substance use may be necessary or desired by the person receiving care before they begin substance use disorder treatment. Individuals should be monitored for signs of withdrawal if they discontinue substance use. Withdrawal management for co-occurring substance use can be complicated, as people may be inadvertently exposed to unknown substances in the unregulated drug supply. For example, you should consider risk of unintentional benzodiazepine exposure in people who use unregulated opioids. Due to the overlapping symptoms of opioid and benzo withdrawal, it's difficult to assess the severity of withdrawal from each substance. Monitor the individual closely to facilitate prompt identification of worsening withdrawal symptoms. If a person is experiencing withdrawal from one or more than one substance, it doesn't necessarily indicate co-occurring substance use disorders. And you can consult with the addiction medicine expert for case-based support. You can contact the 24/7 addiction medicine support line or the RACE app. Co-occurring substance use disorders can be treated using evidence-based pharmacotherapy and psychosocial interventions. As far as pharmacotherapy is concerned, there can be benefits to prescribing treatment for one or more substance use disorders concurrently, but side effects and drug interactions always need consideration when prescribing multiple agents. For the psychosocial section, interventions such as brief intervention, individual or group counseling, or peer support are suggested for all substance use disorders, should a patient desire it. Some psychosocial treatment options that can be offered in these settings and formats include cognitive behavioral therapy, contingency management, and motivational interviewing, among others. Keep in mind that psychosocial treatment alone is unlikely to be sufficient for many people, though it is the standard of care for those with stimulant and cannabis use disorders. As substance use disorders commonly used substances are common, healthcare providers should be familiar with pharmacotherapy options for alcohol use disorder, opioid use disorder, and tobacco use disorder, including concurrent prescribing of these medications. Evidence-based pharmacotherapy is the recommended approach for the management of these substance use disorders. For opioid use disorder, OAT, including Suboxone, extended-release buprenorphine, methadone, or slow-release morphine, is recommended as a standard of care. For alcohol use disorder, acamprosate and naltrexone are the first-line pharmacotherapies. And for tobacco cessation, nicotine replacement therapy and also varenicline and bupropion can be offered. Most of these medications can often be prescribed concurrently. However, of course, naltrexone, which is an opioid antagonist, is contraindicated with the concurrent use of any opioid, including opioid agonist treatment. There are no established pharmacological options for stimulant use disorder or cannabis use disorder, but psychosocial treatments for them can often be implemented concurrently with pharmacotherapy for co-occurring substance use disorders. Let's go through a couple of examples. In our first example, drug-drug interactions and related risks affect treatment selection. When determining which OAT option is most appropriate for an individual who also has an alcohol use disorder, consider that opioids potentiate the effects of alcohol and increase the risk of drug poisoning. Buprenorphine naloxone is likely your best option here. There's a ceiling effect on vital centers in the CNS with a lower risk of toxicity and respiratory depression than for other options. Buprenorphine has a milder side effect profile than other OAT options, including reduced QT prolongation compared to methadone. And there are also fewer drug-drug interactions when naloxone is prescribed for OAT. You should use caution with methadone because there's no ceiling effect. It carries a higher risk of drug poisoning than buprenorphine. There are more severe side effects in profile, including sedation, cognitive blunting, and QT prolongation. And there's more possible drug-drug interactions, especially with antibiotics, antidepressants, and antiretrovirals. You should also use caution with slow-release oral morphine. There's no ceiling effect also with SROM, so it also has a higher risk of drug poisoning than with buprenorphine. It has a similar safety profile to methadone. It's important to remember that SROM's effect on alcohol use and craving has not been studied. Similarly, there are specific considerations for choosing a medication for alcohol use disorder for individuals who are also prescribed OAT. The recommendation is acamprosate, which has an established evidence base for safety and efficacy for the treatment of alcohol use disorder, but it doesn't pose significant safety risks when prescribed concurrently with CNS depressants. However, a reduced dosage may be required for individuals with renal failure. Have caution with gabapentin. There's growing evidence of gabapentin's efficacy for treating alcohol use disorder, but currently it's second line. Gabapentin is known to potentiate the effects of opioids. It increases the risk of respiratory depression and drug poisoning if used at a moderate to high doses concurrently with opioids. If it's prescribed concurrently with opioids, close monitoring is required. What's contraindicated is naltrexone. Of course, in the context of OAT, because naltrexone is an opioid antagonist, which blocks the effects of all opioids, can cause precipitated withdrawal if you were to administer it to somebody taking any opioid, including OAT. Note that while it's contraindicated for people on OAT, extended release naltrexone may be beneficial for treating both alcohol use disorder and opioid use disorder in patients not on OAT. However, unfortunately, this medication is not available in Canada at this time. For individuals who decline OAT, oral naltrexone prescribed for alcohol use disorder may provide limited benefit in treating opioid use disorder as well. Another example is where co-occurring substance use disorders impact treatment selection is OAT for people who use benzodiazepines. According to one large study published in 2021 using US Medicaid data on over 20,000 people receiving buprenorphine for opioid use disorder, buprenorphine has a protective effect against drug-related poisonings in individuals prescribed benzodiazepines or Z drugs. Given bute's sealing effect on respiratory depression, it should be considered first-line opioid agonist treatment for patients taking prescribed benzodiazepines or using unregulated benzos or benzo analogs. Consider methadone or slow-release oral morphine if buprenorphine naloxone is contraindicated, or if the individual has a strong preference for methadone or SROM. Both methadone and SROM have a more severe side effect profile and higher risk of drug poisoning compared to naloxone. Traditionally, prescribing OAT to patients also taking benzodiazepines has been contraindicated. But in light of the high risk of drug poisoning death associated with unregulated opioid use, it's not recommended to delay or withhold opioid agonist treatment if benzodiazepine exposure is suspected. However, patients should not be started on OAT while sedated. Also, remember that many people starting OAT may have unknowingly developed benzodiazepine use disorder due to the contaminated supply. It's important to monitor the person for benzodiazepine withdrawal and offer benzo management as needed. Psychosocial interventions may include brief intervention, individual or group counseling, or peer-led supports and bed-based treatment. Clinicians should share information about the psychosocial care and support options available and offer access to services as requested to all individuals accessing care for substance use disorders. Note that this is not a comprehensive list of psychosocial interventions. However, these are the examples that we'll be talking about today. This slide specifically lists psychosocial treatment options. These interventions have been studied as options for most substance use disorders. However, these are discussed as recommended options for stimulant use disorder in this slide. Based on existing evidence, psychosocial treatment is currently the treatment of choice for stimulant use disorder. The options include contingency management, CBT, motivational interviewing, and combinations of these approaches. Contingency management and cognitive behavioral therapy are especially promising treatments for stimulant use disorder. These options can be offered in conjunction with treatment for other substance use disorders. So, in summary, co-occurring substance use is common and may occur unknowingly. Treatment should be non-judgmental, trauma-informed, and person-centered. Co-occurring substance use disorders are associated with significant physical, mental, and physiological harms. The most common combinations of two substances are benzodiazepines and opioids, cocaine and alcohol, opioids and alcohol, opioids and methamphetamine, and commercial tobacco and other substances. Generally, both disorders should be treated concurrently, but if this is not possible, the disorder that has the greatest risk of mortality or morbidity should be prioritized. Drug-drug interactions and related safety issues should be considered carefully when selecting pharmacological treatment. Recommended pharmacological treatments are available for opioid, alcohol, and tobacco use disorder and can be prescribed concurrently with appropriate consideration of possible drug interactions, including combined drug toxicities. Stimulant and cannabis use disorder do not have evidence-based pharmacological options and should be treated with psychosocial interventions. Thank you very much.